Good afternoon, I'm Raf Poggi, I'm a GP and representing the PCNs in the North.
As everybody's probably guessed, I'm Brian Bennyworth, Councillor Brian Bennyworth. I'm chair of this board.
Jane Buffet, Director of Public Health, Communities and Leisure.
I am Lee Bell, consultant in public health, covering Health and Wellbeing Board, substance misuse and mental health.
Hi, I'm Pratima, Chief Executive of Support Northamptonshire, Healthwatch and Voluntary Sector.
Good afternoon, Rachel Ritchie, Principal Leisure Manager for Active Communities, working for NN Leisure.
Hi everyone, I'm Rachel Clifford, Public Health Principal for Adult Health Improvement at North Northamptonshire Council.
Hello everyone, Sarah Petty, Public Health Practitioner, working in Public Health at North Northampton Council.
Hi, I'm Hannah Scanlon. I'm the Office Manager at Northamptonshire Local Medical Committee, which is general practice.
Hi, I'm Trish Rhinus, Assistant Director for Safeguarding in the Trust, and I'm representing Colin Foster today, who's on leave.
Good afternoon, I'm Troy Hobbs. I'm the Interim Head of Special Educational Needs and Disability at North Northamptonshire Council, Children's Services.
Afternoon, I'm Helen Baines. I'm a Transformation Programme Manager currently working within Children's Services at North Northampton Council.
Good afternoon, I'm Pauline Brennan, working for North Northampton Council.
Hello, I'm Jenny Daniels and I'm doing the minutes.
Thank you very much, everybody, for that. I'm going to move to agenda item 1, which is apologies for non-attendance at today's meeting. Can we have the apologies, please?
We have apologies from Cornelia Andracut, the Director of Children's Services, Philip Pells from Northants Fire and Rescue, Dr Jonathan Cox from the Local Medical Committee, Colin Smith also from the Local Medical Committee, Trevor Shipman from Kettering General Hospital, Colin Foster, represented by Trish, Polly Grimmett from NGH and KGH, Chief Superintendent Steve Freeman and Kate Williams.
Thank you very much. Those apologies are noted. I'm going to move to item number 3 now, which is the declaration of interests. So can I invite board members to declare any disclosable pecuniary interest or non-statutory disclosable interests for the items on today's agenda? If the board declares such an interest, they must remove him or herself from the whole of the item. When declaring an interest, board members are asked to state the item number of which they have an interest, the nature of that interest, and whether the interest is a disclosable pecuniary interest or non-statutory interest. And as per my last meeting, I'd like to start with myself, declaring that I'm a partner governor for NHFT. So that's my declaration of interest for today's meeting. Are there any other interests from board members that need to be declared? No. Thank you very much. We'll now move on to item number 4, which are the minutes of the previous meeting. And can I say a big thank you to those officers that completed the minutes. I thought they were an excellent representation of the last meeting. I didn't realise how much I'd spoken in the meeting, but it was from my opinion, a fair and accurate representation. But I'd like to open it up to the board. Are there any amendments or inaccuracies in the minutes that have been distributed that board members would like to highlight? No. Is everybody happy that, if that's the case, that I sign these minutes as a true and accurate record of that meeting? Could I ask for a show of hands for those in favour? Any against? And any abstentions? Thank you very much. I am happy to sign those minutes. So we now move on to the action log from the last meeting. We have 2 actions that came out of that meeting, which I believe have been distributed to everybody. The item numbers were 100725/02. This is where a breakdown of which groups were included in the 5,000 children with an EHCP by age, sex, and ethnicity. Since publication, this has now been supplied and shared with the board. So if everybody's happy, we can close that action. Yeah, I'm not seeing any dissenters. So the second was 100725/05, which is related to the ICB and Healthwatch working to identify the areas in North Northants with the highest need of dentists. This is an ongoing action, and the 2 organisations are meeting to put together a joint action plan for dental services, including community engagement for those residents that are in areas of the county that have higher risks of poor health outcomes. They will report back before the next meeting. So we'll keep that action open and look forward to that. Okay. Hello, Prince. Please, nice to see you. Moving on to the item number 6, the Chair's introduction. I'd like to wish everybody a warm welcome, particularly to those that are watching on the YouTube channel. It's good to see that those of you are attending for the first time. I'd also like to extend a special welcome to Tyler Hudnott, a member of our Youth Council who is observing the meeting in the chamber. Tyler, you're very welcome, and thank you for coming along today. A reminder before we start to turn off or silence your mobile phones for the duration of this meeting. There are no fire alarms planned for during the meeting, so if the alarm sounds, please leave via the doors at either end of the chamber and vacate the building using the stairs. We encourage all board members to contribute to the discussions, but please do raise your hand and wait to be recognised by myself as the chair before speaking. This will ensure that everyone is clearly heard and helps our minute takers. I've received a request from the Director of Public Health and Leisure to hear an item that falls under the category of any other business. This will be heard at the end of the agenda. So on to item number 7, which is our Health and Wellbeing Strategy update. This is a verbal update on the work streams. I'd like to first invite Lee Bell to start this item.
Thank you. I'm a little bit late to this one because I was on holiday up to yesterday and was told yesterday I was doing this, so I'm hoping I've got all the detail right on everybody's behalf. I think the first thing to talk about is a little bit about the history of the Health and Wellbeing Board strategy, that it was agreed in 2024 with 5 key priorities, with an executive sponsor, a work stream and a public health support officer. It's a dynamic plan that sits underneath each of those priorities, and that's what I'm going to be talking about today. I'm not going to be talking about smoking and vaping because that is one of the key items, so I'm just going to stick to 4 of the strands. Progress is tracked and monitored by the Health and Wellbeing Strategy Oversight Group, which I'm a key member of. So I'm going to start with strand 2, which is keeping active. These are from updates from each of those leads. So at the moment, there's 4 working groups established to deliver the 4 objectives of that strand: healthy communities, connected communities, thriving communities, and green communities. Each is led by a system partner and takes forward a priority of the Health and Wellbeing Board strategy and the active community strategy in harmony. Each working group leads a share of the quarterly highlight reports to the wider active communities partnership, so there is an interconnectivity of governance. And there's opportunities to identify cross-group opportunities and to improve the efficiency. So it's not just a Health and Wellbeing Board strand, it's something which cuts across all parts of the council and the area itself outside of the council. And as part of that work programme, Public Health are conducting 3 needs assessments, keeping active, healthy weight and healthy ageing, which are linked to those parts of that strategy, so that we've got an evidence base and align these to the identified needs. So again, it's not just one strand that sits on its own, it's something that's interconnected with each of our work streams. Strand 2, mental health and wellbeing. We've proceeded with the suicide prevention and awareness training across the county, so across both west and north. And at the moment, the final commission has been written based on relevant evidence, and we're looking at expressions of interest. So at the moment, working with our procurement lead to make sure we're doing that within proper process and governance. We've also looked at 2 pieces of work for opportunities within the Health and Wellbeing Board strategy with some short-term funding. The first is to look at short-term projects, and the second is to address needs in the system for longer-term projects, which will go beyond a 12-month period. Again, they're based on good evidence from our needs assessments, they're based on our population profile, and they'll be out to commission within procurement process. We're not sure at the moment what that process will be, so I'm unfortunately not unable to tell you what that's going to be just yet, but it will be part of the Mental Health Learning Disability Collaborative to be able to say, actually, this is how we want this to work, and make sure that that's equally available to any prospective bidder that is able to deliver those projects. There is a male suicide prevention campaign which is taking place on the 16th of October at Northampton Museum, which is including a screening of a campaign video which Public Health and the Mental Health Collaborative have been involved in. And I think quite a few people will have been to the Baton of Hope tour, which came through Northampton in September. Feel free to ask any questions as I whistle through it. Children and young people, there have been a number of actions during this year. Through the Family Healthy Weight Programme Steering Group has been meeting. 3 work streams have been established which align with the Health and Wellbeing Board objectives. And the Children and Young People Public Health Team agreed that to lead on the Keeping Active Children and Young People work stream, working alongside active communities. Again, a joined up piece of work which is based on local need and the evidence that's been presented. Also looking at healthy weight interventions which have been commissioned and provided by other local authorities. So doing a marketplace evaluation. What else is out there and what does the evidence tell us would work in this situation? What we've also started doing is hosting healthy weight workshops with system partners. So looking at a compassionate approach to healthy weight for young people and building on that partnership arrangement. So there's been 60 attendees so far from a variety of diverse organisations and some work with Groundworks to develop the interventions to support that and to support the National Child Measurement Programme. There's also been some work around schools and family hubs recently coming into public health. And looking for opportunities to embed physical activity as a rounded offer and a successful Keeping Active workshop. There's also been some work around oral health with system partners and some funding received to deliver early years supervised toothbrushing, wrong agenda. And the 4th strand around financial resilience. There are some commission-funded programmes supporting financial resilience. Those have been continues. They're not fully mapped yet, but there is a plan to do that. There's a theory of change specification developed with the VCSE leads to ensure that that's a fully engaged group, and that specification is well informed by all partners. There's been A specification sent out an invitation to bid for grant funding within September, and reports brought back in from previous commissions within those strategic grants. The annual year one report relating to this is in draft form, but will be available within the time frame. And there is some more funding confirmed to 25-26 around employability, digital and essential skills through the adult learning services, and a significant achievement obtained through those reports from the current services, so around financial gains from benefit advice and support. So that's a whistle-stop tour of the 4 key areas and their action plans.
Thank you, Lee, and thank you for riding in from your holiday to give us that update. Before I pass it on, I'd just like to offer out to the board, has anybody got any questions that they want to pass on to Lee? So, David, over to you.
Lee, thanks for that really helpful update. Just when we're looking at arranging events, particularly around suicide, I was reading University of Northampton and Community Foundation report that generally indicates that the prevalence of depression and mental ill health is higher in Kettering and Corby than in any other urban area in Northamptonshire, and whilst a bit aged now, there were 11 suicides per 100,000 reported in North Northamptonshire and 8 per 100,000 in West Northamptonshire. So it'd be really good if, when we're having events, for example, around male suicide, whether we could look at some of our more challenged areas in North Northamptonshire as potentially places to host those.
Thank you, David. I think that's a very good suggestion, and I'm sure we can take that away and look at that. I attended the Baton of Hope event across the county. I think it was 2 weekends ago now, and got to speak to many people. And I am attending the event on the 16th of October next month at the Guildhall in Northamptonshire. So. It's an area of personal interest to me, but also, I want to try and be an advocate and an ambassador for raising this issue, because I think it's very important. Jane, over to you.
Thanks, David. Just to say, I think if we could all plug that training with all of our organisations, that would be really helpful. So suicide is much more common in men. 75% of suicides are of men in a particular age group. And it's also the case that there are some groups who are at particular high risk of suicide. So, Dave, you'll be aware that people leaving inpatient psychiatric units, for example, are extremely high risk. So it'd be really great if organisations could make that commitment to ensuring staff do the training that's available, and maybe have discussions about what else you could do as organisations. And if you need any support, then we're here to also support you as organisations.
Thank you, Jane. Have I got any more questions for Lee? Prince.
Thank you, Chair. Just to echo one thing. On the issue of suicide, from the voluntary sector perspective, where we've actually seen a gentleman in his early 40s who nearly committed suicide. And so I think the training in terms of having that within our voluntary sector, including our volunteers, to kind of being able to identify and pick up some of those things will also be very useful, and how probably system partners can, create that pathway for volunteer within charitable organizations to kind of have some of those materials or learning in a more collaborative format to make sure that we are also aware of and identifying and referring in that process. That will be useful.
Thank you, Prince. I think that's a very, very helpful suggestion. I am aware of quite a lot of material that's available, free training material, but I don't want to plug particular ones, but I think something that we can take away and look at and how we can do that more collaborative piece. Any more questions before I move on? Yeah, Dr. Podgy.
Yeah. I like to add that, the opportunity to link up this work with the very early stages of development of the neighborhood health centers. We are very much looking at, definitely catering all the north areas where we can really strengthen that relationship and create the basis for neighborhood health centers. That doesn't need to be a physical center. It's just that, opportunity for different organizations to join together in the way they're working and build the links. So very much appreciate the work that's been done so far by all the teams, especially in suicide. And when I do reviews of, death under 50s, there is a lot of that. And the people you mentioned, they appear on my list. So anything we can do to strengthen, and I will link, if it's okay, with Lee to see if we can bring it into the neighbourhood work.
I think we may have our first action of the meeting. I certainly would encourage that, and thank you for offering that. And Lee, I'm sure that you'd be happy to link up and see how we can join things up in a far more structured way.
Yeah, we'd be happy to do that. It'd probably be useful to do that within the governance structures of the Mental Health Learning Disability Collaborative. And I would say also in terms of the training, there is a plan through that board to, and at the moment it's out for people to bid to deliver this training. But there are, I think you're probably aware, Prince, that training has changed over time. Initially it was about developing our own local training, but as Councillor said, there are lots and lots of modules that are free to organisations to use. We're looking at a more enhanced one, which will be available to VCSE colleagues as well.
Thank you, Lee. I'm now going to hand over to Rachel Clifford, Sarah Petty and Chris Holmes. Chris, I think you're on my agenda as, to give us an update on smoking, vaping and keeping active.
Thank you. I'm going to provide an update on the smoking and vaping part of the workstream, and then can hand over to Chris for keeping active. I'm Rachel. I'm presenting on this on behalf of Pippa, but I also have Sarah with me, who leads on the children and young people's strand of the smoking and vaping workstream. So the purpose of this report was to provide an update on this strand of the Health and Wellbeing Strategy, and in doing that the report provides an overview of the national and local context, outlines some of the activity under the Smoke-Free Generation funding, as well as an overview of the delivery plan. It also identifies some future planned activity in here as well. The report recommends that the Health and Wellbeing Board notes the progress that has been made so far, supports the next steps, acknowledges how joint ownership and system working has really propelled some of this work forward, and needs to continue in order to reduce prevalence of smoking, which we know is a priority for Northamptonshire and has that kind of profound impact on the health of our residents. In terms of national and local context, smoking remains the leading cause of death and ill health in England. It's responsible for 1 in 4 cancer deaths and 9 out of 10 COPD cases. It's also a key driver of inequalities, and in Northamptonshire, we perform worse or equal to the regional and England average in terms of our prevalence. We have 4 dedicated work streams of activity in the Health and Wellbeing Strategy strand, and these include increasing the number of residents supported to stop smoking, providing targeted support to population groups with higher prevalence of smoking, addressing smoking and vaping in children and young people, and disrupting the sale of illegal tobacco and e-cigarettes, and as well as reducing underage sales. In the first work stream, which relates to increasing the throughput to our stop smoking services, we have expanded our in-house stop smoking team to increase capacity. That's been driven by a big recruitment drive of advisors, but also an operations manager who now runs all that kind of day-to-day provision. As a result of this, waiting times have reduced from 8 weeks to only 1 to 2 weeks currently. And it also means we've been able to add additional clinics to areas identified with lower uptake. It means we can be more proactive and respond to activities like Stoptober, which we are heading into tomorrow. And we have a whole calendar of activity for Stoptober with our advisors out every day in October and doing engagement activity. We also have procured a Stop Smoking app, which is due to be launched in the next couple of months and certainly ready for our new year quitters. That means people will have access to support 24/7 and also on their terms. It also hopefully means we'll capture some people who wouldn't have ordinarily accessed the Stop Smoking service, so it gives us a new cohort of people to engage with. Under Objective 2, so providing more targeted support, we've had a real focus on those working in routine and manual occupations. We've been working with the Corby local area partnership, as Corby has our highest prevalence in routine and manual smokers, to gather some insights to understand the attitude to smoking and stopping smoking in Corby, which we should have a final report by the end of October. This will shape what a smoking offer could look like moving forwards and kind of in co-development with those cohorts. We have also developed a clear evidence-based framework for how to support local employers who want to address smoking in their workforce. Under Objective 3, which Sarah has been leading on, we are looking at preventative activities focused on smoking and vaping in children and young people. A new working group has been established, and this includes a wide range of stakeholders who have put together a delivery plan for the work stream moving forwards. There is also being work with secondary schools in developing a resource hub to support teachers, young people and families around smoking and vaping. And this is being implemented for our Healthy Schools team. And then finally, under Objective 4, we've been working to disrupt the sale of illegal tobacco and e-cigarette products and reduce underage sales. And we've done this largely through a joint initiative with Trading Standards called Operation Stop. As part of this, we carried out test purchasing and enforcement activity with support from Northamptonshire Police, and we now have a newly developed reporting function on the website too. A training programme as well as comms activity also accompanied this, and that was really focused on increasing awareness and encouraging reporting. It's also allowed us to identify effective media assets which could be used more routinely moving forwards. In terms of issues and improvements, we're looking to embed more quality improvement approaches so that we can maintain performance alongside the quantity of people that are accessing our services. We will also be focusing on continuing to increase throughput to our services, and that will include a number of comms assets as well as engagement with local organisations to try and improve those referral pathways into the service. There is also an ongoing system-wide activity where we're reviewing the future models of tobacco dependency services in NHS settings across North Northamptonshire. As we know, the evidence indicates they are an effective system approach to reducing smoking prevalence at a population level. We will be using the work on routine and manual occupations in Corby to develop improvements and adaptations to our service and plan to have a clear plan for future targeted work in other areas, for example, in smoking and pregnancy, or those with severe mental health or severe mental illness. We will also continue to strengthen our support to schools and colleges and work with Northamptonshire Tobacco Control Alliance to review and refine their priorities moving forwards. So lots going on, lots of progress has been made, but certainly, I guess, more to do, and hopefully the board can continue to support that partnership element, which we know is really important if we want to make progress and reduce those smoking-related inequalities. Thank you.
Thank you. I'll just stop there. Are there any questions for Rachel or Sarah on smoking and vaping? No? I'd just like to say I've been out and about during the summer. I've met the team at various family activity events and things, and truly remarkable the work that you do. I learnt quite a lot myself, so thank you very much for what you do. If there's no questions, I'll hand over to Chris.
Thank you very much. Thank you. I'm trying to learn a new... I've just had my prescription of my glasses changed. I'm trying to learn a new skill and I find myself getting a bit of a taffle. Hopefully you've had a chance to read the report. I'm not going to go through it word for word, but I did just want to sort of talk through a few personal reflections, I think, really, about the way that the Keeping Active theme is going and the active community strategy that sits beneath it. The one big thing, I think, when we started out with the strategy was that it was never going to produce one big, magic, brand new interventional programme that was going to solve the physical inactivity issues that we have across the population. No big silver bullet. It was always going to be about the way that the people and the people and the system within which they are works better, more effectively, more joined up. And I think we are really beginning to see that now in the work to deliver on the Keeping Active theme. What we have are a number of things. One is a really big movement of people. You know, there's 35 or 40 people plus involved in the partnership group and others beyond it in the thematic groups that are all playing their part in some way or another. I think we're seeing a lot more joining up then, because all of those folk are around the table and talking to each other, coming up with ideas. And I think at the last count, I counted over 15 services just within Northamptonshire Council of various sorts that are all involved in those discussions, because we knew from the start it was never going to be something we'd just solve through the sport and leisure team alone. So lots of connections being made, lots of collaboration. For example, one of the themes, the Greener Communities theme, is being led by the head of service from Country Parks, and she's doing a great job of pulling all the work together around that. Another thing I think we're seeing in the strategy is more community. I mean, it says it in the title, Active Community Strategy, but at the heart of that is a bit of an acceleration in the way that communities are being listened to and worked with and co-designed with to deliver what we're trying to deliver, which I think is just brilliant. As an example of it, we have an opportunity, thanks to Sport England, working in Kingswood and Queensway and Lodge Park, and are already engaging really closely with those communities, hosting days that are not about putting sports stuff on, but listening to what the issues are in those communities and seeing where physical activity could play a part in improving the lives of people in those spaces. So Stuart, who's part of that team, is just doing a brilliant job. Two more things just to finish with. We spoke about people at the start, the number of people that are involved. I think we're seeing a slight change, perhaps, in the way that people are working on this, or in terms of mindsets and behaviours. We've done quite a lot of work within the Keeping Active theme to try to support that as well. So over 50 colleagues from Northamptonshire have gone through, we call it our system leadership programme, but it's about looking at system change, system thinking, working differently, not just assuming that we can come up with an idea of buying a dog for everybody to go for a walk and that will get everybody active. It's much more about how we're working together. So a lot there. And then finally, much more reflection and learning, the use of insight, and insight not just in terms of numbers and graphs, but insight in terms of stories and what we are hearing and understanding from communities being built into, as a sort of an evidence base, being built into the programmes of work and the work that the thematic groups are doing. The University of Northampton is supporting heavily with us on that, and then public health colleagues too, with the physical activity needs assessment that they're working on, is also really, really helpful in that regard. Just to finish, it was in a terrific meeting about 4 weeks ago. Rachel was in it as well. And it was one of those ones where we went into it not really knowing exactly what the outcome would be, but it was all the themed leads sitting around the table with 3 or 4 other colleagues as well, swapping ideas, sharing knowledge, seeing connections, agreeing to go away and work on something together. And there was a massive energy in the room, which was really, really good to see. And I think that's just a kind of a common atmosphere that there is in this work at the moment. So, not sure if that was the sort of full update report that there should have been on the paper, but the reflections on how the work's going, and happy to answer any questions.
Thank you very much, Chris, and thank you, Rachel, also. I think from my perspective, just my short time over the summer, what I've been hugely impressed with is the amount of collaboration and system thinking and working across the piece. Quite frankly, it blows my mind to see how much is being done in Northamptonshire. So, if in this position for the next few years I can help facilitate that even further and play my part, then you have my absolute assurance that I will do that. But I'll open it up to any other questions. Prince.
Thank you, Chair. Chris, that was a very snap overview, and thanks for that. I just wanted to find out whether in the form of clarity or commitment in terms of how are we assisting local grassroots organizations to have a sustainable keeping active agenda, because we see that some organizations try for a couple of months or weeks and then they drop. And others locally then tend not to get into the habit because they don't have that resource to do that. So how are we trying to make sure that there is that sustainability at the grassroots level?
Yeah, thanks, Prince. So I hope that what I have perhaps just reflected on is that because this isn't about booking a venue, booking a coach, putting on a program, publicising it, and keeping doing that until the money's run out. This is an approach that is, we hope, about building the capacity of voluntary and community sector infrastructure organisations, our local community clubs, those that are within our communities that are just eager to try to be involved and want to try and do something to improve their areas. We're desperately trying not to just do it to people, but to do it with people. I'm not sure, I'm sure there are times when we could do that even better, but that's at the heart of the community strategy approach. It's very much at the heart of the opportunity within the community strategy of the Sport England place expansion work as well. We're one of 80 places across the country that Sport England are investing in to do it just in that way. So listening to communities, building that community's capacity, so that the change is made forever.
Thank you. I'm going to bring Pratima in.
Chris, I know it's really early days, but given the Sport England expansion are in the same areas of Pride in Place funding that's been announced, and I know local authority will be looking at that, just early indications of, obviously, it's a really good platform you guys have created in those areas to then build from as well.
Yeah, and it will just be a very quick answer. I suppose the key thing is that we feel like the Keeping Active theme and colleagues working on it are in the right places to be working alongside those that will also be thinking about how that investment can work for those communities, because worst of all would be that, left hand, right hand doesn't know what it's doing. So first step is to be in the right rooms, and I think colleagues are. Thank you.
Thank you, Toby.
Yeah, thank you. It's a kind of open question to the two workstream updates. There's some hugely sort of encouraging work underway under both strands, so thank you for that, and I think the comments reflect that. And particularly from an NHS perspective, I'm conscious we spend a huge amount of our time and resource dealing with the consequences of ill health, often associated with smoking or low levels of physical activity. The question, you've presented the progress in the areas that are moving. Are there areas that you've wanted to get off the ground that you've been struggling with for whatever reason? And are those issues, barriers, obstacles, things that any of us around this room, I'm conscious of our role as a Health and Wellbeing Board in trying to support and move things on, as well as receiving progress updates. So just interested from either of the work streams, other things you've been trying to get moving and you've just not managed to get it into this kind of update because it's not where it needs to be. Thank you.
Thank you. I think there will be. I think what we've seen in smoking and vaping is that there was that huge kind of, that system focus has been so important, and having all the players around the table has really been able to move things on quite quickly. I think that the next few years of that smoke-free generation funding are quite ambitious in what we want to achieve, and there will be probably, I would imagine, places where we will need that buy-in and support to be able to progress things forward. So not specifically at this second, but I think there will absolutely be, asked of the system, and because I guess the scope of what we want to achieve becomes more complex, we need more partners on board to be able to drive that forward. It's really been about, I guess, to this point, building up the service to be able to meet the needs and the capacity of people coming through. But in terms of that kind of wider tobacco control work and some of that working with organisations to get people through to the service, there'll definitely be asks moving forward.
Thank you. I think that, Toby, that one of the biggest opportunities for us that we have not tapped into fully yet is to have threaded physical activity a little bit more tightly into the enormous capacity that there is across the health system and the health workforce. In particular, we know of really great examples of PCNs and GP surgeries that are really, really good at understanding the benefit that physical activity can bring to people and know where to signpost people to. But I feel like we're only tapping into the edges of that at the moment. And I would hope that we can do that in a way that's not asking extra of people, just it's giving us to give extra help and support to that workforce so that they can take our message into their work.
I'm going to bring Jane in now.
I think one of the areas that we've struggled with smoking particularly is where we want to move to prescribable medications. As a service, we really have been struggling with that. This is a national issue, actually. So if we could work more with different partners in the system, and we have done some work with Northampton General Hospital around this, I believe, with Philip, that would be really great. We're getting more people wanting that option. So the new drugs that are coming out, which can be of benefit to some people, would be great to offer that as well. But obviously we need help with prescribing and things like that. So there's that side of it. But I think we're getting there with that, and we're hoping to get to a point quite quickly where we can offer that. So we want as wide an offer as possible. The other thing I think that is a challenge is, well, there's two challenges. One is that communities where smoking is at its highest, it's very difficult to really break in sometimes to those communities to talk about smoking. So when we talk in Corby, for example, and we talk about the high rates of some ill health in Corby, the conversation doesn't always come straight to smoking, when we know that actually smoking prevalence is so high and it is at the core of a lot of the issues of ill health. So we really do need to focus on that. And the other issue, of course, is that the whole system is stretched and the NHS is stretched. So how we make sure that we've got the right offer in hospitals around smoking, because there's been some issues and changes in relation to that, that's been a challenge. But also how do we work better with our primary care colleagues to say, what else could we be doing to support primary care? And actually, I always catch Dave's eye, in terms of mental health patients with SMI, for example, what else could we be doing that's a bit innovative in that space? So there are things that we want to do. I think one of our main challenges is to get the workforce organised for it, because we've had to do a lot of recruitment to get to this point. So I think that's something that we'll probably need to take forward quite soon.
Okay, thank you, Jane, and thank you to everybody that's contributed to that debate. Sam, do you want to come in?
Thank you. That's a really important point there, actually, Jane, around the mental health. So I was at the MHLDA exec workshop yesterday, and there was some really good conversations in the room about how we take things forward. There was also, so Paul Birch really helpfully brought some population data, and when you see the health inequalities, particularly in relation to mental health, it's really interesting. But we're all trying to achieve so much, and all of our organisations are stretched, and I do wonder whether there's some cross-collaborative interaction there, potentially linking to new models and neighbourhood health that really helps us to get under the skin of some of that. And it feels like we should pick a few items and do them really well. And actually that smoking mental health link and trying to feed that into some of the collaborative work potentially is something that we can explore.
Thank you, Sam. I'll bring Jane back on that.
Totally agree, Sam. And also, the simplest things are most effective. So when it comes to smoking, if we could, as a system, getting everybody talking about smoking so that, we know that our primary care colleagues, for example, have done a fantastic job. It's very rare that you go and see a GP now, for example, or a practice nurse, or when you're not asked about your smoking. So we need to make sure that we're really getting that across all aspects of everything we do, that everyone's having that critical conversation, but that crucially people know what to do with the answer. It's not enough for some people just to be signposted. Some people need active referral into the services. One of the things we are investing in this team and as part of this work is to say, what is the art of the possible? What else could we be doing? So at the moment we've got our NHS partners, so primary care, but we've also got NHFT and Kettering General and Northampton General. But what we really need to say is, well, how do we work most effectively across the system? So we're putting a post together that will bring together a plan for how we work most effectively. So, for example, is it that we need to have our services doing in reach with Dave's inpatient services, for example, or do we need to have a specialised service within NHFT that links hand in glove with our smoking cessation services? So that post is coming online to help us really imagine that, because I think what we've never had time to do as a system is to really say, where are the gaps? How could we do that linkage better?
Thank you, Jane. I think that's a very interesting point that you made, and for me, what's running in the back of my mind is how do we pull this together? So I probably need a little bit further discussion with you all, but I think it's really important that we take the points that have been made around the table and actually turn them into actions. So that's something that I'm very, very keen to do. So I think, Lisa, just making a note of it, I haven't got it formulated in my head what that looks like, and I'm sure I'll need a lot of help to do that. But if we can just make a note of how do we bring all of those strands together. Dr. Podgy.
Yeah, it's just to raise an example that, recently primary care started making direct referral to pharmacy first. Very simple, very easy, instantaneous, signposting to pharmacy first. And I wonder if the same model can be used to refer people to the smoking teams. Because, I understand signposting is not always effective, because once the person has heard smoking is bad, you're going out and that's finished. But signposting and followed by a direct referral, provided it's made easy, is doable. We've seen it working and it's possible. So if we can learn from that, it might help.
That is something that we should be doing. I mean, every system I've worked in previously has got an ability for GPs particularly and practice nurses, for example, to be able to press a button and it does an immediate referral. So that's something that we'll pick up. The other thing I'd really like to be able to do is give you feedback, so that when you've got a patient that you have referred to us and they've gone through that process, whether successfully or not, that because that's been a big request from GPs for a long time, and that can't be beyond the wit of the system. So that's something else we'll look into.
That's great. I'm going to bring this item to a close now, but thank you everybody for that. That's been really, really good. So I'm going to move on to agenda item number 8, which is the Director of Public Health Annual Report. Each year, every Director of Public Health is required to produce an annual report. The report Jane is going to present covers the period from 2024 to 2025 and focuses on the delivery of the North Northamptonshire Health and Wellbeing Strategy. There is a short film that accompanies this report, which is great because I like a short film. I'm going to hand over to Jane to present the report. Thank you, Jane.
Thank you, Councillor Bennyworth. And before we show the excruciatingly embarrassing video, just wanted to raise a few things. So this is a statutory requirement to do a Director of Public Health report every year. It's an independent report. And it's also a report that gives us the opportunity to focus on particular areas. So the first report last year, which was my first report, really focused on the development of the Health and Wellbeing Strategy. And that has been, I think, really pivotal to the development of some of the things we've been talking about this afternoon. This year we're focused on two particular aspects, so the keeping active and smoking and vaping themes. Next year we'll cover the other three themes and give a really deep dive into those. I think there's a couple of things I'd like to raise. One of them is a reflection on what you said actually, Chris, is that there's very little in public health that is simple to solve. There are some things like vaccinations, so please do have your vaccinations, that's a strong message. But most of our problems are complex and take lots of different organisations and lots of different people to do something different to get the outcome that we achieve. And one of the main strengths, I think, of the way that this board is working around that strategy is that it is doing that. It's designed to be a dynamic strategy so we can change it if things aren't working. It's also designed to be doing things differently. It's not just an assurance document. It has got funding attached to it for some of the innovative projects that we've seen going forward. So it is very much a living document, and hopefully you'll get a sense of some of that in the very short video that is to come. The other thing I just wanted to raise is that the public health report obviously goes slightly more broadly into the work of the public health team. And I just wanted to give a flavour of what else has been going on, because it's really important to understand that this report is a snapshot. It's a very long snapshot, I have to say, but it is still a snapshot. And I just wanted to raise a few things that the team have been doing. So the one thing that I would say is that this year we've come to a fully staffed team for the first time. So when I joined 2 years ago, I've just celebrated my second anniversary at Northants, we had huge gaps in our service in terms of staffing, and we had lots of interim agency appointments. We now don't have any, and we have a fully staffed team, and they have been working extraordinarily hard to really move things forward in a way that I think is fantastic and is really evident in the report in terms of progress. Whilst doing all of that, we have recommissioned and mobilised 0 to 19 services, so that's all those services around health visiting, etc. That's a huge piece of work. We've done the same for sexual health, we've done the same for drugs and alcohol, for Healthwatch contract, for NHS health checks. So all of this has been going on at the same time as the work that is described as a snapshot in this report. So I would like to take this opportunity, Councillor Bennyworth, to thank the public health team for their dogged determination, is the best way I'm going to describe it, but also thank all of the partners that have supported the team to be able to achieve what they've been able to achieve in this last year.
If I can just echo that last sentiment you made, Jane, that I've been hugely impressed by the public health team, and on behalf of the board, if that's all right with everybody, I'd like to add the board's thanks for the work that they've done. We've got the video. And the video?
I always hope at this point it doesn't work.
Okay.
Report, which is all Hello and welcome to Northamptonshire Council's Director of Public Health Annual Report for 24-25. My name is Jane Buffet, I'm the Director of Public Health Communities and Leisure for Northamptonshire Council, and I'm here to take you through some of the key highlights from this year's report, which is all about the first year of our local health and wellbeing strategy. Our Health and Wellbeing Strategy is a 5-year plan and focuses on 5 key priorities for Northamptonshire. These are smoking and vaping, keeping active, mental health and wellbeing, children and young people, and financial resilience. The report this year has taken a really focused look at two of these big areas of priority for North Northamptonshire, these being smoking and vaping and keeping active. It's been a really busy year for the public health team and all of our many partners across the system, and I'm proud to say that progress is already being felt across our communities. So smoking is still the #1 cause of preventable death and ill health in England, and we are really committed to supporting the government's target of becoming smoke-free by 2030. In North Northamptonshire, 14.8% of adults smoke, and that is higher than the national average, but we also know that rates of smoking are higher among certain groups. So in routine and manual workers, for example, that figure rises to 21.8%, and with people who've got long-term mental health conditions, it's nearly 30%. And what we know is the difference in life expectancy for people with serious mental health conditions is really linked to the fact that there's such a high prevalence of smoking in this particular group. So looking back to 24-25 around smoking and around our services, we have really strengthened our stop smoking service here in North Northamptonshire. We've added 5 new staff, we've expanded our face-to-face clinics, and we have focused support in areas with the highest smoking rates. This is making a real difference to our local population. Over 1,600 residents have set a quit date in this year, and 67% of those have been successful in quitting smoking. Our waiting times have dropped, and at the moment our waiting times are just 1 week. We've also increased our targeted support to groups who are most likely to smoke or at more risk from the effects of smoking, and this does include pregnant women, people with mental health conditions, and also those who work in routine or manual work. One of our really big areas of success this year has been the launch of Operation Stop, and it really demonstrates how we work as a public health function with lots of partners across the system. It's a joint initiative with North Northamptonshire Council's Trading Standards team and also Northamptonshire Police, and it targets legal tobacco and vape sales within our community, and especially to underage users. This has been hugely successful, and as a result, the project has enabled the seizure of over 230,000 illegal cigarettes, nearly 65 kilos of hand-rolling tobacco, and more than 11,000 illegal disposable vapes, as well as many other counterfeit tobacco products. And this is particularly important because we don't know what is in illegal counterfeit items, we don't know how dangerous they are, but also particularly for cigarettes, we don't get the tax income from that. So it's so important that we work in partnership to really make sure that we're tackling that as effectively as possible. So smoking and vaping are really big areas of focus for us, but so is making physical activity something that more people can take part in, because being physically active is a really effective tool in terms of improving our health, our well-being and our quality of life. Being physically active helps prevent heart disease, diabetes and depression, it reduces social isolation, improves mental health, and really importantly it supports a healthier ageing, and that's something we all want for our futures. One of our big areas of focus in this last year has been our Active Communities Partnership. This partnership brings together the Council's leisure team, the NHS, voluntary groups and community stakeholders. And together the partnership has delivered a wide range of programmes, such as our Activity Buddy Coordinator programme, which really helps match people with tailored support and local opportunities to get moving. It provides encouragement, guidance and a personalised route into a more active lifestyle. Our Wellbeing Walks programme has been hugely popular this year, and it's now offered weekly in 32 locations with 124 trained volunteer walk leaders. The walk leaders are so important to this work, and we've seen cases of people who have started running nervously, they've not necessarily had the confidence to even go on one of the walks, who are now leading those walks as volunteers and making a huge difference to their own health, but also then the health of other people who are really participating and enjoying that opportunity. I hope this year's report provides a clear picture of the direction we are taking and the priorities we are setting to improve the health and wellbeing of all of our residents. I look forward to speaking to you again next year with more updates from the team and stories from a successful 2025-2026.
Thank you, Lisa. Thank you, Jane. And thank you, David, for rescuing our ears on the sound. I'd like to just open up for any questions for Jane on the public health report. Does anybody want to make any comments? Or David, over to you.
Thank you, Chair. Jane, thank you for your video and your report. I suppose going back to your challenge around a lot of these issues are stuck and they're difficult to solve. When you start reading through the report and you look at some of the indicators which perhaps we don't perform as well on, or we perform around the England average, but it doesn't feel right. So, for example, 50% of our care leavers suffering or experiencing emotional well-being issues. How do we, as a Health and Wellbeing Board, galvanise around an issue like that and say that's not acceptable? It's higher than comparators, it's higher than what we see in our general population of children and young people. So how do we mobilise the constituent parts of this board and say we all get behind an issue like that and try and address it? Similarly, healthy weight in reception years, 23.4% overweight or obese. Feels like a universal issue. So how do we get behind that? And despite it performing at or around the England average, 37% of 10 and 11-year-olds overweight or obese. How do we mobilise? What more do we need to be doing? Because these dials, I've been here a bit longer than you, Jane, so 4 years, 11 months, not that I'm counting. These dials haven't moved significantly during that time. They are problems that have been around for 5 years at least, and certainly have been around longer than that. So what do you need from us as a board to help try and move the dial? Because public health can't do it on its own, children's services can't do it on its own, the NHS can't do it on its own. So how do we get together and drive some of these, you know, really significantly important indicators in the right direction?
Thanks, David. Just starting on your first point about that indicator of, I looked after children in excellent care and children in care. One thing that's really important to note is this board does not have to only focus on what the key issues are for the Health and Wellbeing Strategy. And it may be that we decide as a board that corporate parenting type role that we all should be taking really seriously as organisations, and I'm sure we are, can allow us to galvanise around issues like that. So from a public health perspective, we do fund some particular initiatives for children who are looked after to help them both in that transition but also support them in their health and well-being because it's so important. But we also know that there's other things that the council does and other organisations are doing that really helps in that space. And so perhaps it would be really helpful to bring a topic like that specifically back to board. One of the things that I'm interested in is the role of the anchor institution work. So the social value work and the anchor institution work, there are loads of opportunities for us as organisations to really prioritise those young people in things like work placements, in things like apprenticeships, and really doing something different for that particular group. And I think that could be, David, something that we bring back. The issue of healthy weight, so like many things, particularly healthy weight in children, has been directly impacted by COVID. There's a national problem where we've seen huge spikes in the number of children who are overweight or obese, and we do need a system response to that. So one of the work streams in the Health and Wellbeing Strategy is around healthy weight for children. And what I find quite interesting about that work, and Rachel, you might want to come in on it, is one of them is about not stigmatising that and being kind in that space. Actually, I think that's a really important thing for us to recognise. But also that we, a public health intervention that we might commission, for example, a family healthy weight type opportunity. But actually what really makes a difference is things like physical activity. It's about opportunity to access good food that is affordable and that is healthy, and people know what to do with that food. It's also about the opportunities that people have to use and access the green space that's around where they live. So you're right, it is a system approach. Rachel, do you want to very quickly talk about the work of that strand that's just looking around young people's healthy weight and whether there's any opportunities for people to be more involved in that?
Yeah, sure. I think it's definitely an untapped an area that we can do a lot more in at the moment. So we're looking at a potential compassionate approach to weight, what that looks like, how we reduce stigma. We're exploring that not only in the healthy communities, kind of children, young people strand of the active communities work that's going on, but also through the healthy ageing needs assessment. So we're looking at kind of what the evidence is, what best practice is doing in that area, what's innovative, what is being piloted currently, and thinking about how we can bring that all together. So that compassionate part, that stigma, but also food systems, food sustainability, all that kind of area of work that there is lots of pockets of things happening in North Northamptonshire, but it's bringing it together and having that systems approach and everybody getting around the table and doing that.
The other thing to bear in mind that is a particular area where there isn't a huge evidence base. And that's another part of what we should be doing, is adding to that as well. I think if we're going to do this properly, we would look to also evaluate everything that we do in a way that's robust enough for that to be shared more widely than North Northants, because we do have big holes in the evidence base about what is the most effective way of doing some of these complex issues and addressing them. So we need to evaluate, and we also need to be an active research partner.
Thank you, Jane. Prince.
Thank you, Chair. Jane, that is very, very great. I just think the question is just general. So if you have an ideal kind of wish to report next year, overcoming barriers, challenges, and obstacles, what would that be?
Just repeat the last bit of the question, Prince. My hearing's a bit...
Right, so basically I'm asking, so next year, if you have to give another report, what will be that ideal report that you would like to give?
An ideal report? The ideal report is we've solved all the problems and we don't need to talk about smoking, vaping and physical activity anymore. But we know that's not going to be the case. We know this is a long-term piece of work. I think for next year, what I'm hoping for is that the partnerships that are working so well have developed even further. I think that would be really great. I would really like to be able to say to you that we've got greater involvement of residents and of people in the work that we're doing in terms of planning, delivering, evaluating that. That would be great. But also I'd like for some other areas of work to be taken forward. So in the financial resilience space, ultimately, if you're not financially stable, the rest of your health and well-being is hugely at risk. And that's just an obvious statement to make. So I'm going to come back and talk about where they have, so there'll be some update on these areas, but where they have progressed and where the challenges exist still in that space. So from a children and young people's perspective, there will be a focus on healthy weight, for example, in that area. We also know that we're going to be delivering lots of health needs assessments as part of this work over the next year. And I'm hoping that what they're going to be able to show us is where our real areas for target and real focus are, so geographically, but also in terms of population. But also that we know what interventions work. We know there's some evidence gaps, but we also need to be innovative in that space, Prince, and be a little bit risky. You know, if there's something that we want to try and we can fund that, we should be doing that, evaluating it really robustly, and then saying, given the findings of that evaluation, we either stop, we continue, or we actually go on a wider footprint.
Thank you, Jane. I'll bring David Mayer in, please.
Thanks, Chair, and thanks, Jane, for a great report and a really brilliant video as well, which I think will be really helpful for populations to kind of look at that. Just on David's point, I think there is something about the specificity this board can highlight in terms of the things we want to address over the next year and what we're asking anchor organisations or big employers in the county to participate and make a contribution to. So I think if we can get to being really specific, if childhood obesity is one of those areas, I have every confidence that members of the anchor network would be able to galvanise and mobilise behind that and think of ways of supporting that in their local footprints. And I think the point you make about the link between poverty or unstable employment and health is really strong and well-founded in the evidence. So I think equally, and I've mentioned it here before, there is something about how this board intersects with some of our planning infrastructure to make sure that employers that come into the county do provide a good living wage, do provide meaningful contracts of employment, do have good workplace occupational health schemes, etc. All of that should be a benefit of a board sitting in a local authority structure. So just to kind of re-emphasise that, because I do think that is an opportunity for us under a new political regime. Thanks.
Thank you, David. I think that's a really powerful and interesting point, and I think it serves to show how this board can reach across many, many different strands to actually bring together a more sort of prosperous and healthy population. So I think we'll take that point away, and I'll talk to Jane about how we can think about bringing that back to the board for more meaningful discussion. If there are no other questions for Jane, I'll bring this item to a close. The board is asked to note the annual report. It's not for voting on, but I think looking around the room, I can say that we can duly note that report. Thank you. Okay, going to move on to item number 9 now, which is the Better Care Fund quarterly update. The Better Care Fund supports people to live healthy, independent and dignified lives through joining up health, social care and housing services around the person. This report covers the performance in the first quarter of 25-26, and I invite Samantha Fitzgerald to present this report. Over to you, Sam.
That's lovely. Thank you, Chair. So this is the Better Care Fund update, and I think there'll be some people in the room that are really familiar with the Better Care Fund and maybe some that aren't so familiar. The really good news is you're going to get familiar with it, because I bring a Better Care Fund update to every Health and Wellbeing board, and I just try and factor different things in. So just to put a little bit of context around the Better Care Fund. So it's been around for a long time, so I think about 2015, and it's really critical in supporting our people to live healthy and independent, dignified lives. And that's by bringing health, social care and housing and wrapping that support around the person. There's kind of 2 core objectives, and that's to enable people to stay safe, well and independent and at home for longer, and to provide people with the right care in the right place at the right time. So the way that the BCF cycle runs, or the Better Care Fund, is every year there is a requirement for health and social care to come together to jointly write a plan. And that consists of a number of documents. So there's a large planning template, which some of you may have seen, and that details all of the income that we get for the BCF, all of the expenditure in which ways that we want to spend it. It has an element of demand and capacity modelling, so actually how much demand across our pathways and services do we expect to see, and what's our confidence level that we've got the capacity to manage that. So that's quite a big template that we ask the board to review, and one of the things I really wanted is the board owns that plan, so I might write it along with partners, but it's a jointly owned plan that we feel is ambitious and we feel is delivering the right things for the people of North Northants. We also then write a narrative document, so when you see the schemes and the expenditure and the volumes within there, but you really understand what does that mean for people of North Northants, what can they expect from their health and social care services. So I do that will be coming up towards the beginning of next year. We'll be required to have those new documents. Alongside that, I'm required to bring an update against how we're performing for the key metrics within the BCF plan. And the key metrics within the plan this year are around our rates of avoidable admissions for our over 65s to hospital. A new metric for this year was around delayed discharges. So actually how many people didn't leave hospital on their discharge ready date, and then the amount of permanent admissions to residential and nursing care. So I want to talk around those metrics. What I would bear in mind is the metrics, it's always a bit of a funny time. So Q1 was spring, tipping into early summer, and actually now we're finding ourselves in the autumn very much thinking about heading into winter. So just as we go through those metrics, it's always good to bear in mind that they are from kind of like the first quarter. Okay, so if I run through them individually, I'm really happy for people to ask me questions as I go. I'm really happy for a bit of conversation or a bit of challenge to say, well, why is that? And then what I wanted to do is not just tell you what the metrics said, but actually tell you what are some of the plans that are happening across the system to keep those metrics either on track or to improve the outcomes for people. So the first one then, unplanned admissions to hospital. So this one we've classified in Q1 as being off track. So broadly there were 1,117 admissions for people over the age of 65 versus a plan of 944. Now, there is a significant amount of system transformation work happening, and some of that work, because of things like procurement or having to staff up different establishments, has been slow to get off the ground. But we are feeling more confident, and you'll see when I come back in December and I bring you the Q2 update, that we're moving these metrics closer forward. But just to give you some ideas of the sorts of things that are happening in the community and around the front doors of the hospitals. So there's been plenty of additional falls equipment deployed across the county, and we're also now, so we did have a problem with our assistive technology that we were using, particularly with our colleagues in EMAS, around people that had fallen, and if we believe that fall to be non-injurious, that clinicians can understand and safely use things like razor chairs to be able to lift people off the floor, one, to save a trip to hospital, but also to save people a long wait on the floor. There's been increased urgent care capacity, urgent community response capacity put in by NHFT, so that's increasing their capacity from 41 to 47 people per day. And then things like common issues where particularly our older people might get admitted, so catheter care workstreams as an alternative for ED. So they're just some of the things that are happening in around that avoidable admissions space. The next metric that I just wanted to talk through was around our delayed discharges. Now, the delayed discharges have always been a thing. So back in the day, pre-COVID, we used to count something called DTOC, which was delayed transfers of care. But it is really important that people don't stay in hospital longer than they need to, particularly our older population. They decompensate and won't recover to the same levels that they would have previously. So it is really important that we have a focus on this, as well as for all the other reasons that you'll see more widely in the press. So for this metric particularly, we are on track for our performance levels that we set out in the plan. And there's a number of different metrics that make this up. So the first one is the average length of delay for adult patients, and we're currently at 1.5 days versus a target of 1.2 days. But that's not for supported discharges, that's for everybody who resides in a hospital and how quickly they leave. So broadly there or thereabouts. And then the next metric is around the proportion of adult patients discharged on their discharge ready day. And we've got a target of having 80%, or 80.7%. Oh, no, we're at 80.7% versus a target of 80. So again, you can see that we're broadly there or thereabouts. And then within that, that breaks down where would we expect to see people who are having a supported discharge. And we break those supported discharges down into pathway 1, 2, and 3. And then simply speaking, if somebody's a pathway 1, it means they need some support to return to their own home. Pathway 2 means we believe the person's destination is still their own home, but actually they might require some reablement or rehabilitation in order to get them home and as independent as possible. And then pathway 3 should be where we're relatively confident this person isn't able to return to their own home, and therefore we are looking at admission to residential or nursing home. So we would expect to see many more people in pathway 1, slightly fewer in pathway 2, and very few people in pathway 3. And it's quite interesting here. So I want to kind of give the scale. So pathway 1 discharges in that first quarter were 574 discharges against a plan of 592. So across those 3 months, that was 18 people less than we thought we were going to see. And then we said our target to discharge those people was in 2.5 days. We discharged those people within 2.5 days, and that was against a target of 2 days. So we were half a day slower than we would like to have been on that big volume of those nearly 600 discharges on pathway 1. When we looked at Pathway 2, we did 141 discharges against a plan of 120. So actually we were something like 21 discharges over our plan. And on average, it took us 2.5 days to discharge those people versus a plan of 5. So we were 2.5 days quicker to get people into that Pathway 2 for that rehabilitation or that respite. And then Pathway 3, we discharged 90 people against a plan of 78. So actually we were 12 people more that went out on Pathway 3. Now, the reason why there is this focus, and you'll hear people talking about Pathway 3 a lot, is it takes us 18.3 days to discharge somebody on Pathway 3 versus a plan of 7. And actually, when I talked about that transformation work streams on how we improved that, that's why the work around Pathway 3 is so important. So in essence, 18.3 days, that's, you know, just shy of 3 weeks for somebody to get to their onward move. So some of the things that we've got going on in the system in relation to improving those discharge pathways is there's lots of internal work going on within our acute hospitals, making sure that processes are running alongside people's treatment so that everything's ready for when they're there, that they get through to the transfer of care hubs for that decision to be made about onward pathways for those individuals. So there are for winter, there are 29 additional Pathway 2 beds coming on stream, and actually what we're really working to do is say how many of those people in Pathway 2 actually in Pathway 3 actually deserve the opportunity to be given a chance to be re-abled or more independence in Pathway 2. And then there is some looking at whether, so some of our services work 7 days, but not all of them. And then what we seem to see is spikes in people waiting for discharge at certain times. So what we're exploring as a system is what's the opportunity to have some 7-day working in order to be able to facilitate a good level of discharge for people consistently 7 days a week. And then the last metric that I just wanted to come on to is around admissions to long-term residential and nursing homes. So sometimes we use short-term provision to enable people to recover, but this is permanent admissions. And we're currently on track to meet this target within Q1 with 116.6 admissions per 100,000 of the population versus a plan of 137.6. I always caveat this metric with actually, sometimes for permanent admissions, the data can kind of jump up a little bit afterwards, but at the moment, we are on track to meet that target. And again, lower is better. We want to see less people being admitted permanently to residential nursing placements. So I talked a moment ago about those 29 Pathway 2 beds that are actually starting their phased opening from the 1st of September. So some of those are already in operation. Internally within Northants, we've got a bit of a work stream in saying how do we use Thackley Green, our specialist enablement centre, to take a higher level of acuity so that we can take more of those Pathway 3 people to give them that chance of independence and reduce some of those waits for discharge. And then there are additional 10 slow stream rehabilitation beds about to open that colleagues in NHFT are supporting. And again, what we're hoping that will do is just give people a little bit longer to recover and regain independence before making some of those decisions around permanent placements. So in a nutshell, that is it wasn't so much of a nutshell, was it? But that was the Q1 update. I'm more than happy to take any questions.
Thank you, Sam. That was very informative on a personal level, so thank you very much for that. Pratima, over to you.
Sam, thanks for that report. Just to say, I was at the winter planning event yesterday, presenting on Age Well and Support Northants as a model, and clearly all the partners were really focused on upstream prevention, early intervention, all of that. So it was a really good session. First time I've been in an environment where I can observe the winter planning kind of processes. And what was interesting is that there was a really good kind of piece at the front end about, it shouldn't matter to the public which organization facilitates whatever. we need to be really collaborative in our approach. So some really good learning from that, and everybody kind of working together. So it's really good to see. I guess just from a voluntary sector perspective, there are very few voluntary organisations there. I just happened to be there for different reasons, really. So there's really a missed opportunity about the kind of what the sector can bring to that. But also, more importantly, I came away thinking the public have no idea how much work goes on behind the scenes, and a public awareness campaign about look after yourself in the winter. How can you navigate your way to support and services early, so people are not struggling, etc. And just as a kind of an example of somebody we're supporting at the moment, went to hospital to Hackley Green. It took so long to get residential care placement, which is the only pathway for him. Due to brokerage kind of services, lots of some delays there, and he's back in hospital and long stay hospital. So again, it's that kind of are we maximizing all of our collaborative efforts?
Yeah. So the session yesterday was. Sorry, am I okay? It was aimed at frontline workers. So it was that information sharing, particularly from community services, to share with colleagues that work within the hospitals, because I think sometimes it's really good to see what's out there. There will be, as part of the winter planning, there will be and is a comms approach that will release information, public-facing information, to say, Jane's already plugged vaccines, pharmacy first, those types of things that will be released in the kind of planned schedule. Probably not the place to talk about individual people, but the brokerage, so significant work has gone in internally around the brokering of provision. So very minimal delays in that, particularly out the back of Thackley. And in fact, we've done a lot of work. So people have heard me say this before. You can have 51 beds, but if you don't move people through those 51 beds, it's just 51 beds. And actually, we've done a huge amount of work on the length of stay within Thackley, which I think on average is 36 days, but with a median of 14, acknowledging that there will be some complicated people that it takes longer. But the challenge is right, Pratima, because we have to make sure that every part of that system flows in order to make sure that we can support as many people as possible through winter.
Dr. Podgy.
Yeah, thank you. As always, I need to bring up the primary care, because is a partner that is missed out of the Better Care funding for a long time. And this is a plea for next year. One of the targets is the unplanned hospital admission, and the step changed that happened this year is primary care got access to the NARP, and we can really re-stratify population based on the ACG, the Johns Hopkins, so we can identify patients who are at higher risk of hospital admission. So it would be nice in the next year, so after this winter, if primary care can be part of the Better Care funding, to design interventions to target that population that is, measurable, and we can actually do something more proactively to reduce the admissions.
So what we are getting better at doing, I think, is we are using forums like the Urgent Care Board, which has representation when we do our planning. So, we will make sure that the Better Care Fund schemes go through that venue.
Toby.
Yeah, thank you, Chair. This area has a tendency to get quite complicated, doesn't it? And if anyone wasn't in any doubt beforehand, Sam quite clearly is an expert in the field on this over many years, working with us to support. It is, though, really important that the whole of this board kind of gets that this is one of the big statutory kind of duties that sits with this board, which is why it's a standing piece, which is why it comes back here. And the reason for that's very simple, as the conversation's just illustrated, which is pretty much every partner around this table touches this aspect of our services to some degree, some more so than others. Kind of adult social care, NHS obviously centre stage in this, but as we just referenced, voluntary sector, primary care and other partners as well. So this genuinely is one of those absolutely right to be here agenda pieces, because it's all our business. A couple of observations. I mean, firstly, thanks, Sam. There's a huge amount of work that you guys do in this. I know you work massively closely with my team at the Integrated Care Board, with Chris, with Eileen, with Giles and others, including all of those kind of winter planning scenario things you just referenced. There's two metrics in this paper that particularly kind of stand out to me in terms of things that make me anxious, and I know they preoccupy all of us. And then just the thought around the kind of further downstream implications of this, just to remind us why this is so critical. The two metrics in here, you referenced the kind of emissions for 65 plus bit being off track on Q1. I agree with you, Q1 is Q1, so it's kind of one set of data. But I think if I've done my maths right, that's kind of an 18% off in terms of, so a material difference in terms of that level of emissions. Clearly, we're focused on that collectively, and there are things that are stepping up as we go further into winter. But if you just do the simple maths with a kind of constrained bed base within our two acute trusts in particular and community trusts, if we're looking at 18% increases flowing through, that's going to kind of hit in terms of that occupancy piece. And then the second piece for me in terms of the delayed hospital discharges, and actually less the overall average, but more those that go beyond their discharge ready date, because that looks, and I'm not a statistician, but looking at it, that looks to me to mean those kind of drift further out actually than we would want them to once they go beyond that kind of target cut-off piece. So there's a second bit there for me in terms of how that impacts on utilisation and bed capacity. The piece I just wanted to touch on briefly, Chair, in terms of the downstream impact of this paper rightly focuses on the Better Care Fund, which is about discharge, which is about admissions. Where this washes up, and we all know this from our own families, our own communities as we go into winter in particular, is it presents itself in terms of 4-hour waits in ED departments. It presents itself in ambulance handover delays and at times having multiple vehicles stacked outside of ED departments that aren't able to respond to patients in the community. And perhaps for me, almost most concerning of all, it presents itself with the knock-on impact on patients calling and needing what we describe as a Category 2 response from an ambulance service that isn't immediately life-threatening but is urgent. And actually, if we've got all of our crew capacity, which we've had at times pretty much tied up on our two acute sites, we struggle to be able to respond in a timely manner, and EMAS, the ambulance service, struggle to do that. So this stuff is absolutely sort of centre stage to what we do here. I know our teams collectively are focused on it, but I just wanted to bring that to life, Chair, in terms of the impact that has as we go further downstream as well. But thank you, Sam.
Thank you, Toby, and I think you've been very eloquent in your assessment of the impact of what sometimes can see a very dry report, so you made it come to life, so thank you very much for that. Sam, I don't know if you wanted to come back on anything that Toby said.
No, I think it's quite stark, those clear interlinks between where we know we've got challenges. Hopefully the paper and the work that's going on within the transformation teams give an assurance that we've got a plan, we've got some additional capacity, but it still will be tough.
Okay, noted. Thank you. The requirement of the board is to approve the Better Care Fund quarterly report. So I'm going to ask for a show of hands in favour. If you could raise your hand for me. Thank you. Any against? And any abstentions? So I think we can formally approve the Better Care Fund quarterly report. Thank you, Sam. I'm very conscious that we've been going for about an hour and a half now, and just wanted to check on people's comfort whether they would welcome a quick, very quick, because we're a little bit behind time, but a quick 5-minute break, comfort break. I'm getting some nods from Jane, so that means that we will have a quick 5-minute break. The time is now 25 to 4. Could I ask us to be back seated at 20 to 4, please? Thank you very much. Thank you, everybody, for returning to your seats promptly. We'll go on to the next agenda item, which is the SEND Priority Action Plan update. This report covers the progress of North Northamptonshire SEND Priority Action Plan since the last meeting of this board, and it aims to summarise the progress, achievements and challenges. But Troy, just before I ask you to present the report, there is something that I'd like to do, which is to just welcome our town clerk from our Rothwell ward, which is my ward where I sit. So Joe Garner, thank you very much for coming along today. Joe is doing some fantastic things in Rothwell around the health and wellbeing agenda, and I spent some time with her and colleagues just looking at that. So I hope the board don't mind, but I invited Joe to come along today, and I just wanted to say thank you, Joe, for coming along. So Troy, without further ado, over to you.
Thank you, Councillor. Actually, my colleague today, Helen Baines, Transformation Programme Manager, is going to lead the presentation, and I'll be very happy to contribute and take any questions also. Thank you.
Okay, thank you, everyone. As you mentioned, we brought a paper back to the board in July, which was an introduction to the Priority Action Plan, an overview of how it was developed jointly with our local area partnership, and sort of how the governance was set up and so on. Whereas this report is more about the progress we've made to date, key challenges we're experiencing, and what our next steps will be. So it's a bit of a summary. If I jump to some of our progress and achievements and some highlights that we wanted to raise, particularly in terms of leadership and strategy, we have our revised, refreshed SEND and inclusion strategy. This was fully co-produced with parents, carers, schools, social care, health partners and so on. It's a very detailed SEND and inclusion strategy. As I said, it's been refreshed. We've now included our localised outcomes as well, which have been co-produced with children and young people and their families, which are local and of priority to them. And we've sort of developed that into our data dashboard as well, so we're monitoring against those. We've developed our new communication and engagement strategy, so making sure that we're engaging more widely with not just ourselves across the partnership, but also with children, families and the communities. And another major piece of work, which Troy is leading on for us, is our self-evaluation framework update. And this is a really important piece of work. So across the partnership in terms of how we recognise what our strengths are, where our weaknesses are and what we're doing about it. And that's linked to some of the work we're doing around gathering evidence against our progress for our future monitoring inspection. If I jump to commissioning, so we have now a draft joint commissioning strategy for SEND across the partnership. It's currently under review with our partners and going through various governance processes with those. But we are expecting to bring that back to this board in December, so for future reference. And alongside that, there is a delivery plan being worked on. So we're not waiting for that strategy to be ratified. We are ploughing ahead with essential work. In terms of alternative provision and sufficiency work, moving forward, we are looking at potential sites that have been identified. I believe there's eight sites that provided us with expressions of interest. Site visits have been ongoing, and now business cases are being developed. So we're really excited about having additional alternative provision and SEND units, hopefully in the near future. That being said, there are some potential gaps in provision, so what we've been looking at are potential NNC sites as well, and how we can utilise those. So I think there's around 5 of those that we're looking at for feasibility currently. So some really exciting plans there. In terms of governance, our accountability board, our SEND Accountability and Improvement Board, has been refreshed. We have our SEND independent chair in place, Fiona Phelps. We've refreshed the membership, the terms of reference and so on. All partnership risks are now being addressed and reported through our governance structures and are taken to that board as well and monitored closely. And as I mentioned previously, the data dashboard has been updated and linked to our outcomes, because we need to make sure we're evidencing improved outcomes for children and young people with SEND. EHCPs, some significant improvements in timeliness and quality, which are shown in some of the figures that we've shared. Some challenges, I'd say, in terms of we have a new synergy system embedded, so a case management system. It's having a few teething issues, but certainly that's starting to see some benefit. In terms of EHCPs, there's a new quality assurance framework that's been developed. It's been a lot of hard work gone into that. Again, elements have been co-produced with parents, children and young people. So now we're able to monitor more closely our quality of EHCPs as well as the timeliness. And also, I think there's been introduction of parent feedback to that EHCP process. So that's now been incorporated into the feedback and quality assurance part of that process. In terms of accurate and timely assessment of needs, CAMS waits for secondary has halved, which is great. There's backlog recovery programs for ASD, ADHD also underway. An increased SALT capacity across the system, so speech and language therapy services. Preparing for adulthood strategy has been started to be draft, which is another key piece of work and an area that was identified as a weakness by Ofsted, when they came in. And we have a dedicated task group set up for that. And we're already making some improvements in terms of signposting information and making the necessary linkages across the partnership. Some of the key challenges, ongoing challenges really are workforce capacity. So we have some ongoing recruitment retention pressures, particularly in CAMS, speech and language therapy and specialist SEND roles. So that risks slowing service improvement and adding strain on existing staff. But there is mitigation in place. There is sort of recruitment underway to address these issues. Sufficiency, one of the challenges has been limited external interest from schools, especially in the secondary provision. So as I mentioned, we're looking at opportunities within the NNC estate, but also there's a lot of active engagement happening across schools to address that as well and build some interest in developing that capacity. Resources generally, I think this common thread, are stretched across multiple work streams. But we are looking to bolster support through an enhanced project management support offer. So we're looking at increasing our dedicated team that help provide that support and project management methodology around it. So hopefully that will provide a bit more capacity across that programme. Health waits continue to be a challenge at the moment. So work is underway to strengthen support whilst waiting. And that's one of our key work streams, looking at that. Transitions as well, support for young people moving into adulthood. Currently isn't consistent, but there is a dedicated group looking at this. So as I mentioned previously, we're looking at communication, signposting, our local offer. There's a dedicated team looking at making necessary improvements to the local offer, creating awareness and improving the information that's available there, and developing a strategy across the partnership to do that. We're working on building better relationships with schools and alternative provision providers, but there's further work needed to build and maintain alternative provision confidence and engagement generally. So that's definitely being addressed. And clearly the financial pressures as well. The high needs block deficit continues to be a significant risk. There's a lot of focus on that currently in terms of a recovery plan. We're meeting very actively to address that. Next steps, we're very conscious that we're at the end of our 18-month period from when the inspection first came to us last January. So we are very focused on inspection readiness generally and preparing for a potential monitoring visit, which could come any day. So we've built a plan in place, so that's built up with several work streams, looking at evidence collection, as I said, building our CEF, logistics planning and so on, so that we're ready, but also making sure that against all of our plans we have evidence in terms of outcomes and the so what, because that's very much what they'll be looking at is you've developed all these, you've implemented all these things, you developed these plans, but what's the impact and significance for children and young people, and are they seeing a difference and improvement? As part of that, monitoring our progress, we have our next DFE NHS England deep dive coming up. So that's the 20th of October. And what they're planning to do is focus on our priority action 4, which is the big one. And that's the one about accurate assessment and timeliness of needs. And that's quite a multifaceted action in itself. So that's going to be quite an interesting deep dive that we're preparing for. But we also have our 6-month stock take. That's the more official stock take that happens, and it's reported. So that's on the 17th of November, and they'll be looking at overall progress against the priority action plan. So other next steps, finalise and embed our SEND commissioning strategy. We need to embed our outcomes framework and our ordinarily available provision framework as well, which is another key piece of work. We will sustain EHCP timeliness and roll out person-centred practice training, which if you have any questions, I'm sure Troy can support you on that. Advance our sufficiency work, as mentioned, so continue to do site condition surveys, more engagement. Continue our backlog recovery in health services, particularly ASD and ADHD, and strengthen transition planning and preparing for adulthood pathways are very much a priority. And I think that's generally what we wanted to cover. So just a general summary of where we are with things at the moment. As I said, we're very much into the review and sort of reviewing how we are, period, in terms of the so what, and also looking at our partnership as a whole in terms of how we've matured in terms of our partnership working and leadership across SEND.
Thank you, Helen. That's a very comprehensive summary, and I'm sure it takes a lot more work in terms of time than we've got here to go into, but very much interested in the evidence-based outcomes and the so what question. I think that's really important for us to, as a board, to understand. So obviously, keep updating this, and good luck with the inspections that you've got coming forward. I'd now like to open it up to any questions. David, over to you.
Thank you, Chair. Thanks, Helen, and nice to see you again. Really helpful report. I think it's great to see what a grip you've got on performance, the areas which are doing well, but also those areas where it's not been possible to sort of sustain that. Just, can I take you to Appendix A, the middle chart at the top of page 1, which is the open and overdue EHC assessments. There was a massive improvement in the reduction of those up until July. If we were to extend back the previous couple of years' trend, is that spike something that we always see in July because of things like availability of schools, availability of parents to sign off plans? Or is there something else that's impacting on that that's driven that back up to the level which it's back at this moment in time?
Yeah. Thanks, David, and thank you, and well spotted. Yes, it's a little bit of a trend, so there will typically be, on that chart, what you're seeing in that July measure, you have to really go back to the previous 4 to 5 months, because the July measure is the activity that would be due to be delivered largely in that period. And so that does reflect the February-March slight peak that there typically is, in requests for statutory assessment, but not to that extent. And what we hypothesise has happened there relates to something which Helen mentioned and I mentioned in my previous time here, which are our implementation of our new management information system, Synergy. We are our data and intelligence colleagues, and we are doing a great deal of work in cleansing data, because we are seeing anomalies such as this. And I suspect very much that that's an anomaly which is compounded on when there is a typical small rise in business at that point. But to go back to the point, as you rightly said, that chart represents the number of assessments, the timeliness of them, and you could see that there was a massive impact on that, and sustained impact from, for example, increasing the staff cadre in the education, health and care team, revision of the practices within that team, training, more efficient ways of working, and some of the benefits of the Synergy tool that are working for that team as well. So I would very much like to say it's an anomaly, and we will definitely be able to report a sustained improvement on that in the future. But thanks for spotting it.
Thank you, David. Thank you, Troy. Toby.
Yeah, thank you, Chair. Just a brief comment as one of the statutory partners in this space, kind of recognise the update and the huge amount of work that our teams are jointly kind of progressing here. What is particular to just acknowledge, I think, the contribution that Fiona's made as independent chair. I'm really kind of welcome her input and leadership in this space, and from an assurance perspective to this board in terms of committee, in terms of oversight. Fiona's been very effective in mobilising chief executives into a regular conversation with her that gives her the ability to tell us straight, which is what she does, what she's finding, what she's concerned about and what's going well. So she meets with myself, she meets with Adele, the Chief Executive Council here, and also Colin Foster, but jointly with the three of us on a monthly basis. And actually I've really welcomed that because it's her opportunity to just give it kind of straight to us in terms of where we're at. So recognise the progress, but I think hopefully some assurance for this board that that leadership is absolutely there in terms of that accountability. Thank you.
Thank you, Toby. I think we can recall for the minutes our thanks to Fiona and her ongoing work to hold everybody's feet to the fire. Prince, over to you.
Yeah, thank you, Chair. Helen, that was really good report. I'm picking up on 4.2, the fourth paragraph, where it stated that risks remain around program deliverability and potential impact when, reducing ICB resource, talking about joint commissioning, local joint commissioning capacity. Now, to what extent and what will be the impact of that reduction in ICB resources if that were to happen? I know you've kind of talked about some other mitigating strategy, but can you kind of throw a little bit more light on that?
Toby's asked to come in on that, if that's okay.
I just wonder, Prince, from an ICB perspective, it might be more appropriate, Helen, for me to comment perhaps rather than you picking that up. My reading of that is that will be a reference to the only reductions we're making from an ICB perspective, and I'll come on to this in a later item in relation to our running costs as the organisation, so not the services that we fund, but to the staff that we employ to do the work we're undertaking. So we've been required by government to set out plans to reduce by about a third our overall running costs as organisations. I'll say more about that in a subsequent item, but I think that's the risk that this is referring to, the risk in terms of commissioning capacity to support the work. Clearly the things we are doing in that space are making sure we prioritise those critical areas and functions, and that we, wherever possible, take greater resource out of some of those less essential and less core functions, but that is going to have a material impact in some spaces. I'm less anxious, to be fair, at the moment of the impact in this arena, given the importance of it, not just in North but also in West, and actually in the neighbouring patch in Leicestershire and Rutland, where we just had a send inspection in Leicester City in the last week as well. So this is a big agenda across the whole of the ICB cluster, but the report is right to note that there are some changes happening which will impact on some personnel and some capacity, but it's the support side rather than the direct commission services.
Thank you, Toby. Any other questions before I close this item? Okay, thank you, Toby. Thank you, Helen. Thank you, everybody that's contributing. So we are asked as a board to note the progress of the priority action plan. I think we've had some good debates, some great comments, and I think we can do that. We can do that, so we can note that for the minutes. Okay, moving on to agenda item number 11, which is the Healthwatch update. So this report gives an overview of the initial stages of Healthwatch North Northamptonshire following the awarding of the contract in April 2025, and covers the progress, challenges and future plans for the service. So I'd like to invite Pratima to lead this item. Thank you.
Sure, thank you, and I'm really pleased to be presenting this kind of first formal report of Healthwatch. Before I do that, just to introduce you to Claire Nielsen, just sitting there, her first Health and Wellbeing Board meeting for North Northants. She's the service manager for Healthwatch, and we're really pleased to have appointed Claire. A lot of people would know Claire from other work she's done with the ICS and ICBs across over the last 2-3 years. So really good to have Claire on board. And we've got Yaya, who's came from Northamptonshire Mind, comes with a lot of mental health experience and research background as well. So really good team to have in place. Just to say, Chair, that we will be presenting quarterly reports, so you will have a lot more detail. This report really kind of summarizes how we're mobilizing around the work, and particularly in light of kind of national changes with Healthwatch England being abolished, we are looking at kind of, and as are other health watches across the country, looking at the core purpose of health watches, which is primarily about giving voice to communities and making sure that they're, whatever takes its place, we do retain the independent voice of people accessing health and social care services. So we've been kind of involved with, I was saying to Toby earlier that we are kind of in touch now already with Leicester, Leicestershire and Rutland health watches as part of the cluster arrangements with ICB, and that's proving to be really helpful already in terms of those joint conversations. Just to say that we have already got kind of early indications of what people are saying in our communities. In our first kind of report, we're saying people are finding access and booking difficult, particularly around primary care. Some issues around quality of treatment and compassionate care. We know we have demographic gaps from data that was collected previously, so we want to make sure we are hearing from all communities. And more older people and women are reporting their health issues. So that's really good. We want to make sure all communities are able to report anything they need as well. So our key purpose really and key aim of the next few months is to increase awareness of Healthwatch. So you'll see Claire and the team very actively out there. You might see her over and over again. But we'd really urge you to help us get people aware of Healthwatch. We've got leaflets, and all of them are translated as well, and we just want to make sure people know to contact us. And that community engagement is really important, that we hear from people who may not have a voice otherwise, really. So our priorities are kind of getting set, particularly around primary and community care, both experience of people accessing primary care, but also trying to tackle things like digital exclusion. I'm really keen, as part of this being part of Support Northamptonshire, we're really focused on taking action as opposed to just hearing the voice and then reporting that in. Where we can take collaborative action with partners, then we want to do that so that we get to solutions quickly, rather than just talk about some of the issues that people kind of continuously tell us are their needs. Mental health support services is a real priority. Adult social care. I think people, through the branding of Healthwatch, don't often recognise that this is a voice for people around adult social care as well, and we're finding that. So again, that kind of really matters to us. And then, of course, hospital healthcare services as well. We've kind of more naturally kind of built some connections already, and without us having to ask where we can do some enter and view. We've been approached by Kettering General, so we've just completed 3 days of work with children's wards and 4 other services there. So it's really good that they approached us, and I haven't seen the final results yet because our staff were there this week. But really good to know that that first one is complete, and that takes views of parents, carers, children, young people, but also staff on those wards, etc. And then we're doing another one for the Urgent Treatment Centre in Corby as well. So that's great. Just giving you a number of case studies. What's interesting from those case studies, I won't go through all of them, but it's really interesting that Healthwatch does give us that ability to be able to contact the ICB or adult social care or the CQC actually quite directly, and you can get really quick solutions, quick bits of advice, and so things don't have to escalate. We're really keen on things not having to escalate to health services or adult social care, which we know are already stretched. So anything we can do to kind of get people to the right services and support is what our aim is, really. And just to say that the way comments and experiences people come to us is through the Healthwatch England website. They have a have your say kind of function, so you can come nationally. We've got our own website. People can come and have your say on that. We have a telephone line that's open, and then we're now doing lots of community engagement events as well. So lots of ways to get to us, really. And lastly, just to say that again, the opportunity that this work creates is for us to be able to seek other related opportunities, really. And we've already levered in against a contract value of 120,000 per year. We've already levered in about 60,000 from an ICB grant for supporting more black people into getting involved in research. That's 15,000. The People's Health Trust has funded us for a 2-year project on the impact of discrimination in health, and that's £40,000. And then the National Institute for Health and Care Research, NIHR, have just funded us to do a grassroots leadership in research, so the staff can get really more expert on doing kind of research work. So hopefully really good news, and we're on our way, really. Thanks.
Thank you, Pratima. Thank you for the paper and the update. It's quite remarkable when you think that we've just started our arrangement in April of this year, how much work has actually gone on. And from a personal point of view, as chair of this board, I'd just like to thank Claire. Claire was one of the, after my first meeting, was one of the first people I reached out to on a concern that I had, and she responded magnificently, and I've got a report back which I'm considering. So thank you, Claire, very much for that. Open the floor up for questions to Pratima on the report. David.
Not so much, well, maybe one question at the end. I can't get away without asking a question. Much in the line of Brian's, just congratulations on mobilising the service as quickly as you have since April, the soft launch in June. You can already see from the report that you're managing to get under the skin of some of the challenges which are being faced by people, managing to leverage external funding in to help with research projects, are really positive in that sense. I found the case studies nice, simple, but actually they really bring to life some of the challenges that people are facing, and how we might learn from those and try and shape our services moving forward. The question really is, how do we help you to develop Healthwatch as a trusted brand, so that more people engage with you? Because the bigger insights come from the more people that you manage to engage with, understand more about their experiences. So how can the Health and Wellbeing Board members help to support you develop your trusted brand and promote it moving forward?
Thanks, David. I mean, it's a really good question, and I'd really urge all of you to kind of believe in it in the first place, that actually it is an independent voice of people. And like I say, I think because we're taking an approach of this should be supportive to the health and social care system, because we understand the health and social care system really well. So we want to provide solutions here as well, so people don't feel ever more frustrated about the same issues. So if I take the GP surgery and digital access, we all know that's a real bugbear. It's a real issue, and we want to, I've said to Claire already, we need to have some really clear action. Let's look at national good practice. Let's do something really quickly, be it videos, be it stuff in different languages, whatever we need to do to then give solutions to people to say, this is how you can access services. Digital is not going to go away. It's the way to go. That's the way forward. So it's about how we can train communities to be more digitally literate. And again, the voluntary sector plays a part. So I'd really, really urge you all to kind of, one, believe in it, but also please promote it alongside everything else you do as well. We don't know the future of, and I'm being as open as anybody else, we don't know the future of Healthwatch. We fundamentally believe that there needs to be an independent voice for people. So I think that if we can get to a point jointly where we're not all having to do separate bits of community engagement. We think we can bring that expertise here. So if you have community engagement plans in anything you're doing, please do approach us for that, because we do reach communities that you might not be able to reach or haven't got the capacity or the resources or the time to do it. So I think that there's a real sense of kind of we have more to offer than just the Healthwatch, individual bits of inquiries coming to us. So I would like to shape it in a different way, really. Does that make sense, David?
Thank you. I'll bring Jane in now.
Just to echo what David said about the mobilisation, it's been super quick, and it was quite difficult at the beginning because we commissioned it, but it was such a great response from your organisation to really get that going. Obviously, there's been a huge issue since you took the contract and won the contract, is that the national announcements around the future of Healthwatch, and a very sudden announcement that the future of National Healthwatch was coming to an end. I just want to be clear that we have committed to supporting this organisation, this Healthwatch North Northamptonshire, for a 2-year period. And that's been a commitment that we wanted to make because we can see where you're going with this. There's lots of really good work going on, lots of community engagement and very responsive service.
Thank you, Jane. Any other questions from any of the board members? Thank you, Pratima, for that. We'll close that item. So the board is asked to note the contents of this report. I think I'm safe to say that we can do that. Thank you. Okay, moving on to item number 12, which is the ICB update on reconfiguration and on neighbourhood health plans. Toby Sanders will give us a verbal update on the ICB structure, followed by, it says here, a presentation of the neighbourhood plans, but I think Toby is just going to be, oh, there it is. Okay, before I invite you to speak, Toby, on behalf of the board, I'd just like to congratulate you on your appointment to the Leicestershire, Northamptonshire and Rutland ICB. That seems like a huge task, but I'm sure we wish you well with that new appointment. So over to you.
Thank you very much, Chair. I really appreciate your warm words. You're right, it is a huge opportunity as well as a huge kind of challenge in terms of scale. I'm conscious, well, A, of the time, and we're into our final 15 minutes of the meeting, and also we've got two very different items tagged into this kind of agenda piece. One, a bit of an update on some of the organisational changes, and then secondly, the neighbourhoods piece. And in terms of the neighbourhood slides that are on screen, I know I've got two colleagues to the left here, David is a regular member, and Nikki Adams, who leads on this work for us as an ICB as well. So I will just be fairly brief, if that's okay, Chair, in terms of some of the change piece, and then keen to hand to them for what is, frankly, the more interesting bit than the organisational change stuff. But just on the first of those things, I'm particularly mindful as well that we've got a number of new colleagues around this room as well in terms of attendance. The Integrated Care Board, the organisations that I've led the last few years here in Northamptonshire, is that bit of the NHS that is responsible. We don't directly provide services. We're a commissioning organisation. We're responsible for planning, for strategy, for resource allocation, for contracting, for oversight of quality and safety of the services that we commission. And here in Northamptonshire, we channel invest about 1.8 billion in terms of health services, so really very significant resource across community, primary care, acute, ambulance services, aspects of continuing healthcare and so on. And we do that through actually quite a lean organisation already. We only employ a couple of hundred staff here in Northamptonshire, actually in North Northamptonshire, quite literally. Our office is at Haylock House in Kettering. And over the last few months, we've had nationally the publication of the 10-year plan for the NHS, which sets out a really kind of clear, ambitious agenda, particularly focused on three big shifts: that shift from illness to prevention, from acute to community, and from analogue to digital. And running threaded through all of those, a massive focus on neighbourhood services and how we develop and strengthen the way we work across various partners to impact on delivery in those areas. But the NHS 10-year plan also set out some pretty significant changes to the way certain parts of the NHS are structured and resourced and the way that they will run. And in particular, from my perspective, material changes to the way integrated care boards will operate. There are currently 42 of those integrated care boards across the country, and we have 5 of them at the moment within the East Midlands. And national policy has asked us to reduce our running costs by about a third. And that's the cost of the staff that we employ, the buildings that we use, the equipment that we use. So having looked at that and worked with colleagues across the East Midlands and Midlands, it's kind of led all of us to the same conclusion, which is in order to do that and still keep the staff that we need in the areas that are focusing on areas like SEND and the neighbourhood work, we need to be leaner, we need to streamline, and we're going to have to work in partnership with neighbours. So we are in the process, and it's a horrible management phrase, but we're in the process of what we call clustering with one of our neighbouring integrated care boards in Leicester, Leicestershire and Rutland to the north of us here. Clustering means we're going to work together really closely, but we are not merging. This is not about merging those two organisations. The budget and the funding allocation we get for Northamptonshire will remain in Northamptonshire, so this is not a merger of statutory organisations. But what we are doing is bringing together quite a lot of behind-the-scenes stuff that don't normally get seen from a public perspective in terms of the governance and the plumbing, if you like, of the organisation. So we're going to streamline our board arrangements into single board meetings in common with a single chair, Anu Singh, who will start literally tomorrow, who's been appointed into that role, myself in a single care chief executive role, and also moving to a single executive team that will lead the 550 or so staff across both of those organisations. And over the course of the coming months, we will set out our plans to reduce that workforce piece by that 30%, a third or so, across the two organisations. Combined population, that means that we're then working across Leicester, Leicestershire, Rutland and Northamptonshire is just under 2 million. Combined budget is just over 4 billion in terms of health spend across those two areas that we're accountable for, and 550 or so staff working across those two areas. So some quite significant change and quite a lot of impact actually from a staff point of view. I'm very mindful of the staff that work in the organisations that I lead, the important work they do and the need for us to support them through this period to stay focused on what is likely, I suspect, to be a fairly lengthy transition as we go through this. This isn't going to be done and resolved in the next couple of months. We're going to be working this through this transition period probably over the next 12 to 18 months. So happy to come back, Chair, if it's helpful to talk further at subsequent points. Just very specifically for this board, that new larger geography that I shall now be working and leading across is made up of 5 local authority places. So we have 5 health and wellbeing boards within that geography. Just a very personal note for myself and also my chair, it won't be feasible for us to be present at all of the health and wellbeing board meetings in person, but our absolute commitment is that we will nominate an exec director and one of our non-exec directors from the board to be a constant presence and link so that you have a point of consistency. And then myself and Anu as chair will make sure that we kind of work our way around over the course of a year as well to stay connected and involved. So I think that continuity piece is important in terms of relationships mattering. I'll pause there unless there's any particular questions on that kind of first part before we perhaps turn chair to bring in Nikki and David on the neighbourhoods piece.
Thank you, Toby, and thank you for that clarity around. I think it's important, the consistency point that you make, particularly for this board, but for all boards that are going to be affected by this reorganisation. So thank you for bringing that clarity today. Are there any questions for Toby on what he's just described? No? Okay then. Well, with that ado, I'll hand over to David, and I'm really sorry. Is it Nikki?
Nikki.
I'm really sorry. I couldn't see a nameplate.
Sorry.
Oh, confused me.
Thanks, Chair. I've got a hard stop at 4:30 to chair a meeting at 5, so I'll keep this section brief. I'm just going to give a bit of an update on neighbourhoods. Just a few things to say. First is not much of this is particularly new. It's been kind of trailed through the Integrated Care Partnership Board for a number of months. It's also not new in policy terms. It's been in place through policing for a long time at national level, neighbourhood models of delivery of policing. We're now pushing into healthcare models of neighbourhood delivery, and increasingly you'll see education in that frame too. So that's kind of just sets out a kind of a broader kind of policy context nationally and locally for us. Just next slide, please. So just to kind of reconfirm where we've been, system in place remains the taxonomy or the nomenclature that we're using. So there are two places, obviously north and west, one integrated care system here in Northamptonshire. And then neighbourhoods, we're working across 9 neighbourhoods currently. I know there's work ongoing within local authority footprints around the local area partnerships and just kind of doing a bit of a stock take of how we've got on with those over the past 18 months or so and whether they're still the right size and in the right place. But for the purpose of this discussion, that is the architecture that we're working with, and that is the framework around which we'll hopefully deliver a new model of healthcare fit for the future. Next slide, please. So the principle of neighbourhoods is essentially what's described as proportionate universalism. So all neighbourhoods will get a bit of everything, but it will be proportionate to the profile of need within that neighbourhood footprint. Our local area partnerships then provide a good buttress to that model of healthcare delivery by doing prevention work and supporting us doing that real ingrained community outreach support to then allow a neighbourhood infrastructure to deliver targeted interventions and universal interventions where there's a treatment modality required. Next slide, please. So Toby's described the emerging framework for commissioning these across the NHS more generally, with integrated care boards taking a more strategic role in commissioning. They will help us translate government policy of movement from acute to community, that's the 3 shifts that we've described, how that will be enshrined through a neighbourhood model of delivery in a commissioning sense, and then ultimately our role as a Health and Wellbeing Board in bringing partners together in this work. I have to say our police colleagues have done, amazing work on neighbourhoods for many years, and the granularity of your data in understanding population need is far superior to where health has been, but increasingly health is getting there. So I do feel there's a thread of hope there for wider public service kind of integration and really understanding needs of populations at a hyper-local level. The outcomes, I think, are really important. So earlier Sam described the Better Care Fund outcomes, focusing on length of stay, reduced demand on services. That increasingly will become bread and butter, I suspect, Chair, for boards like this at a local level, supporting an integrated care board in a strategic commissioning sense, and then working with providers and networks of public sector organisations at a neighbourhood and local area partnership level. So really exciting opportunities there. And Pratima's work previously in Support Northants, along with others around loneliness and the wider voluntary sector interface, is really, really important and new territory for us to break into. We've done good work before, but there's a lot more, I think, that statutory organisations can do to really engage with the opportunities of that social capital in local communities. Next slide, please. I'm going to jog through these now. In terms of a connected offer, as I say, the proportionate universalism of having a standard set of provision across neighbourhoods that's common to all. Primary care have been doing this for years, providing kind of proportionate universal care to local communities. There's more we can now do using this architecture to really think about that outreach model and that shift of acute to community care. Next slide, please. And then just to confirm the map of neighbourhoods currently, the population numbers quoted here relate to the primary care general practice registered population, which will slightly differ from local authority. But we think the next phase of the work with this is a neighbourhood board in development to help us develop the sophistication of how we're actually using population segmentation to drive care models, and we'll be working across these geographies as outlined here. As I've said, David and others will probably update on work with local area partnerships more generally. I know there are discussions happening within local authority footprints about the configuration of those, but I think that doesn't detract from us being able to get moving on some of this really and just get on with it, frankly. Great. Thanks, Chair. I'll hand over to Nikki now to talk about new care models.
Thank you, David. I'm Nikki Adams. I'm the Director of Integration at Northamptonshire ICB, and I've been leading on the new models programme. I'm going to give you a really high-level presentation on this today, but I have got a one-page detailed description of what the new models programme is around. It's about if people would like me to distribute that after, so I know I'm going to kind of impart quite a bit of information to you, but I can distribute that for you as well. So in terms of the new models programme, well, we set out on a journey about 2 years ago with the fundamental aim of doing something different. We know, and we've already mentioned earlier, around patient access in general practice, how that's a struggle for patients, and it's a common theme that comes up in all of our worlds. We really set out to say that we wanted to do something different, working fundamentally to try and support general practice and to improve things for patients and our population as well. It's been a difficult few years for general practice, and I'm sure you've seen in lots of the national headlines around general practice is not sustainable in its current format. Now we've been trying to work locally with general practice to try and do something different. I'm just going to pull out a couple of ambitions of the programme because it relates particularly to some of my next discussion. So one of the things that we wanted to absolutely do with this programme is to find a way for general practice to do more proactive care with patients, particularly with complex care and long-term conditions. Now, if you think about the current model of general practice, historically, it's been what it's got its own name now, isn't it? The 8 a.m. rush. 8 o'clock comes on and all the patients try and bombard the GP lines to try and get an appointment. And quite often, those patients are sometimes patients that probably aren't in the greatest need that need those appointments, and those that do need greater need unfortunately sometimes end up escalating into our acute hospital-based services. So we wanted to change the dial on that. We wanted to be able to find a way of supporting GPs, and particularly GPs, to be able to do more proactive care with those set of patients. Next slide, please. So I'm really pleased to say that in August of this year, the ICB board supported the business case for the new models programme, and that business case aimed to do essentially two things, and that was to develop a neighbourhood access service which enabled patients with low complexity care to access services quickly, in full recognition that those patients, the most important thing for patients with low complexity is quick access, and continuity is not always the most important thing for them. Whereas patients that have got complex health needs absolutely need to be close to their own GP practice, and there's been whole sets of models that have been developed nationally around walk-in centres where patients with complex health needs, when you take them away from their registered GP, they don't always get what they need, and they'll end up bouncing back into general practice or into acute services. So we wanted to recognise that we had to design something that was a differential offer for patients based on health needs. So the two components against the neighbourhood access service, adding extra capacity for patients with the low complexity needs in exchange for protecting the time of the GPs so that they can do a different offer and work much more proactively with patients with those complex health needs. So what that means for a patient, well, if you're a patient registered at any GP practice, you would continue to ring your GP practice or access your GP practice in the way that you do at the moment. It remains the front door for the service. When you call your GP practice, the GP will be able to identify whether the level of your needs, whether you're low needs or high needs, and offer you, if you've got low complexity needs, an appointment in a neighbourhood access service. Now, we are, in terms of the investment that we're putting into the neighbourhood access service, in reality it means that we're on average adding an additional 1,400 appointments per week in a neighbourhood, and that's a combination of GP and advanced practitioner appointments. So know that they're the appointments that will be available to those low complexity patients. if you ring your GP practice and you've got complex needs, then absolutely the GP needs to be seeing you in their own practice, preferably by the GP that knows you, that's got the continuity is absolutely important. And by moving those low complexity patients away, what you've done then is able to give them more time to that GP to be able to spend that time with that patient. It enables the GP to move potentially away from 15-minute appointments or 10-minute appointments. So we have a mixture across the county in terms of 10 and 15-minute appointments, and has the ability to have the time to be able to say, actually, you know what, I need to do 30 minutes with you because I actually need to put a proper care plan in place and wrap around the right support with you, working in our new neighbourhood environment. And this is where quite a few people confuse neighbourhoods with the New Models programme. The New Models programme is just one part of neighbourhood working, and actually neighbourhood working is about trying to prevent people from accessing health services. And if we see neighbourhoods as a medicalised model, then we've got it wrong. So the neighbourhood is about taking people out of general practice. But when they do present, we need to be able to manage them more effectively than we are at present. So what we've done in terms of the business case, because this is a new model, is not tested nationally, but it is embedded in national policy. So those of you that are interested in national policy, things like the Darcy report that was published in 2024 and the Claire Fuller report that came early, which was a primary care-based document, you'll see these sorts of concepts around complex care needs and continuity being in a GP practice and more of a neighbourhood-based service for low complexity care, which is exactly what this does. We believe at the moment we're the only area in the country that's fully trying to implement the Claire Fuller report in terms of complex care, long-term conditions and neighbourhood access. It is untested. We are entering into this for a period of, we're calling them innovator sites. We're not rolling this out across all 9 of our neighbourhoods. We're rolling it out in 2. So one in Northamptonshire footprint and one in West Northamptonshire footprint. We aim to go live with them on the 1st of April 2026. And if you just go on to the next slide, I can talk to you a little bit about our timescale for that. I think it's just really important to say it is absolutely our ambition that we move from 2 to 9, and we do that as quick as we can in the county. But obviously this is requiring investment, and we've got to prove that by investing it gets the benefits that we expect to be able to achieve, because that's the way that we recycle the funding around the health system. Obviously we all know there's no new funding entering into the system for these sorts of projects. So I'm not sure whether you can see that very well. So in terms of timeline at the moment, we're on target as per this slide up here. We're currently at the moment invited all of our GP practices across Northamptonshire to come together in their neighbourhoods to express an interest to be an innovator site. We're 2 weeks into a 4-week period at the moment whereby they're deciding how they come together. We're requesting that you have to have at least 75% of your population in your neighbourhood covered to participate as an innovator site. We fully recognise that this is innovative and that not all GP practices in the county may want to participate. So we've set some boundaries around the level of participation needed to become that site. We expect that we will be in a position to name our 2 innovator sites by end of October, early November. And then we will be working with those innovator sites to do what we're calling a period of engagement and co-production. So that's where the GP practices in that neighbourhood work with all of their partners and their patients and decide and design what that model looks like, particularly around the neighbourhood access service. Because there are different ways that they could deliver that model depending on which neighbourhood you're in. For example, some could do it in a hub and spoke type model where you go to a different venue. Some might decide to do added capacity in different practices, but that's absolutely for them to design. This is about empowering the neighbourhoods, empowering the providers to make decisions in the best interest of the patients with the patients. So hopefully we'll start seeing by the end of December have a little bit more detail around how that model might start to materialise in the 2 neighbourhoods. I think that's probably a summary of where we are with the programme.
Okay, thank you, Nikki, and thank you, David. Just open it up for any questions. It looks like really exciting work. It looks like tiring work as well. So I'm sure you're all pedalling very hard. But does anybody have any questions? No? Okay, well, thank you very much. We are asked as a board to note the information and the plan that you provided. And thank you, Toby, for your update also. Could I just ask as an action, you did make an offer to send some information through to the board. I think on behalf of the board, I'd like to accept that invitation, Nikki, if I can. Okay, thank you very much. Right, we'll move on to item 13, which is any other business. And over to you, Jane.
You'll be glad to know this is super quick. Just to say that I've been asked just to share that from, I think the 1st of November, the name of the Urgent Care Centre in Corby will be moving and it will now be called the Urgent Treatment Centre. This is in line with a national move for all urgent treatment centres to have the same name. There will be no change to the actual service that's provided there. And we just wanted to make sure that that was known publicly. Thank you.
Thank you, Jane. You'll be pleased to know, I do apologise, I'm 6 minutes overrunning, but thank you all very, very much for your support today and your attendance. Thank you to our guests. I hope you found it useful, and I will now close the meeting. Thank you very much.